Thank you very much. Yes, in fact, that was going to be my first question, was who is familiar with self-controlled methods? I know at least one of two of you maybe, but...
I think one of my colleagues conducted self-controlled study with air pollution and heart disease.
Ah, yeah, okay.
But, yeah.
But no, yeah, it's not a very familiar topic, I think. Okay, that's good. So the talk I'm giving assumes that you know nothing about self-controlled methods. So if you know nothing, it's for you, it's good. Okay, so we're going to start by thinking about confounding, a familiar topic, and then we'll discuss some situations where I think the conventional study designs may not work very well. And we'll talk about how two particular self-controlled methods, so the self-controlled case series and the case crossover design, we'll talk about how they work, and I'll give you some examples of each of them. We'll talk about the advantages and limitations as well. Okay. So first of all, confounding, and it's the problem that if we're doing epidemiology, it's the problem that we face in almost every study. And it's all about alternative explanations. So it happens when the association between an exposure, maybe a drug, and an outcome is mixed up somehow with some other exposure, which happens to be more common in the group of people who are taking the drug that we're interested in. So this is a familiar concept to all of you, I think. Yeah. Now, I just want us to think about when we approach a study question and we want to make comparisons and how this might be difficult for us to do. So here I've got a cartoon example where maybe we've got a doctor over here, and he has two patients. They're roughly the same age as each other. They're both women, and they both have depression, let's say. And so the doctor has to decide which antidepressant to give to each patient. Now, you can probably see that these patients are not the same as each other. So they're the same age and sex, but I think the lady at the top is more frail than the lady at the bottom, who looks considerably more healthy and fit than the lady at the top. Okay, so they're same age and sex, but otherwise they're quite different. Now let's imagine that the doctor decides to give one of them an SSRI antidepressant and decides to give the other one a tricyclic antidepressant. Now these are two different types, two different classes of antidepressant, and let's imagine that we as researchers want to know, is treatment with SSRIs compared with tricyclics, is it associated with an increased risk of hip fracture? So we know that people who take antidepressants can fall more often. Maybe they get confused or they have low blood pressure because of the antidepressant. So they're more likely to fall, and therefore they may be more likely to have a hip fracture. Okay? So that's a question for you to keep in mind. Another question that we will often have to think about is, let's imagine we have a new vaccine. And in this example, we've got 8 very young patients, young babies, and we've got a new vaccine, and we want to know whether the vaccine is associated with an adverse reaction. Well, let's imagine that the vaccine is given to, let's imagine the intention is that we give the vaccine to all children. Well, we know that in reality, there will be some children who don't get the vaccine. So here we've got 7 of these babies are given the vaccine. One of them, for some reason, is not given the vaccine. Now, if we want to do a study to find out if the vaccine is associated with an adverse reaction, do we really want to compare the seven children given the vaccine against the one child not given the vaccine? Now I think, and I'm not making any judgments, but I think that children who don't get vaccines are unusual or strange in some way. It could be that their parents have some massive objection to vaccines. This can happen. Or it could be that the child is maybe sick or is different to other children in some way. So if we want to do a comparison between children given the vaccine and children not given the vaccine, we may have some major difficulties. So it could be that there is no good comparator group. This would be our conventional approach. Maybe we have a cohort study of exposed and unexposed, and we just follow them up to see what happened. But I think that in instances like these, it could be that the patients in our exposed and unexposed groups are too different from each other. And it may be that we cannot measure the important differences between them well enough to be able to adjust for the confounding that this would introduce. And if we can't do this, or if nearly everybody is exposed, then I think we need a different solution. Okay, so going back to the question of antidepressants and hip fractures. So hip fractures are a big public health problem. They happen particularly to older people, and a woman who's aged 50 has a 17% lifetime risk of having a hip fracture. That's quite a high risk. For men it's a little lower, 6%. But each year, for people aged over 60, 10% of them are prescribed an antidepressant. So if we're concerned that antidepressants may lead to hip fractures, this could be a big public health problem because it's a common exposure and a common outcome. So it's a question that really matters. Historically, people had been using for many years the older tricyclic antidepressants, and we knew that the tricyclics were associated with this risk of falling and a risk of therefore having a hip fracture. At the time in the late 1980s, early 1990s, this new class of drugs, the selective serotonin reuptake inhibitors, were launched, and the perception was that they were safer and they were less likely to lead to falling and therefore less likely to be associated with hip fractures. So this was the conventional wisdom in the 1990s. I've just basically explained that. Then in 1998, there was a big study, a large case control study published in The Lancet, which looked at this risk of fractures associated with both tricyclics and SSRIs. Now, what happened here was, for the tricyclics, the odds ratio for hip fracture was 1.5. Surprisingly, the odds ratio for fracture with SSRIs was 2.4. So this seemed to suggest that in fact the problem was greater for SSRIs than it was for tricyclics, and this was not expected. But this was in a big study where they adjusted for confounding factors, and these were the results.
Can I have a quick question? What's the comparison of these two drugs?
It's against no use.
No use.
Yeah, which we could maybe criticise the design of the study. I agree, but nonetheless, these were the results, and so the question for public health then became: did we get it wrong about the difference between tricyclics and SSRIs? But that's a really good point. So it was against no use. Yeah.
Another question. Did the study include incident user or include also prevalent user?
it would be potentially prevalent users because it's a case control study, so they would just be looking at, has this person recently been taking an antidepressant? Yeah. Yeah. So all good questions in terms of, I think, so this is 20 years ago now, and I suspect that these days we would design these studies quite differently anyway. Yeah, so they're good questions. So back to this question. The idea of choosing between SSRIs and tricyclics and an increased risk of hip fracture. The problem is, and if we think about the first cartoon slide I showed you with the two ladies and choosing between an SSRI and a tricyclic, the question is, are doctors prescribing the newer SSRIs to patients that they believe are quite frail because they want to try and avoid hip fractures in those patients? And so maybe the doctors were channeling those new treatments to the patients who were at higher risk. Does that make sense? I think in terms of clinical practice, I think that would be a good thing. But it means that it may be that this frailty is acting as a major confounder, which is then leading us to think there's a bigger problem with hip fractures for SSRIs than for tricyclics. So as epidemiologists, we can do the best we can to adjust for confounding, but we know there's often residual and it can be a big problem. So maybe this association or this bigger association for SSRIs is actually due to confounding. Because more frail patients are given the SSRIs. So the key issue is how we make the comparison. Who do we compare the treated group against? So I'm going to suggest that one solution is to not have a comparison group at all. And this is the premise or the lead-in to the idea of self-controlled studies. So here I'm going to outline, this is a timeline for a single patient who could be included in a study. So for a self-controlled case series, which is what we're going to talk about first, this is an observation period. So the green represents the period of time over which we observe a patient. The patient can have the outcome at any point over the observation period. In fact, it's really important that they're able to have the outcome at any time. Okay? We then look over that period of time at when they had the exposure that we're interested in. And we call that the period of hypothesized increased risk of having the outcome. And we can separate that period of time out from the rest of the observation period. So here we've got, where we've just got green, this is our baseline. Where we've got purple, this is our increased risk time, and then goes back to just green, more baseline time. Yeah? What we then do is we look at when the outcomes happened related to the exposures, and the assumption is, or the condition is, that the event definitely happened. So everybody in our study will have both the exposure and the outcome that we're interested in. Yeah? So this is a really important point about this study design. Everybody has both the outcome and the exposure at some point in time. Okay. If the event is more likely to happen during the periods of hypothesized increased risk, then it suggests that there's likely to be a link between the exposure and the outcome. Okay? So that's a brief introduction to the study design. Does it make sense? Are there any questions at this stage? I'm going to talk to you more about some of the detail, but are you all with me so far in terms of how the design works? Yeah? Take that as a yes. Okay. So back to our study question, which is how does the risk of hip fracture associated with SSRIs compare with tricyclics? Yeah. So this was a study done in what is now the CPRD. It used to be called GPRD. And the study investigators found 16,000 cases of hip fracture. 80% of them were women. And they decided to do both a self-controlled case series and a case control study at the same time. And they found 30,000 matched controls. They were able to extract information on all their prescribing and the major comorbid illnesses, smoking, body mass index, previous history of falls, all of those kinds of traditional confounders that you would hope to have information on. Okay. So these are how the data looked for the case control comparison. So you can see here amongst the cases, we've got 18% exposed to tricyclics and 6% exposed to SSRIs. Amongst the controls, we've got 12% taking tricyclics and 3% taking SSRIs. In their adjusted analyses, what they found was, here we've got for the tricyclics, within the first 14 days of exposure, their adjusted odds ratio was 4.76. For SSRIs, during the same period, it was 6.3. Now, we notice that the confidence intervals for both of these estimates are quite broad and they overlap each other. But still, the results are consistent with seemingly maybe a higher association for SSRIs, a worse association than for tricyclics. As time goes on, so from 15 to 42 days and over 43 days, this estimate of a harmful association returns towards 1. Okay? So it seems that the risk is increased, especially at the start of treatment, and potentially it's worse for the SSRIs than the tricyclics. So that's the case control results. For the self-controlled case series, this was the design. So they had again in red, the baseline time, both before and after any treatment. And then they've broken down the high-risk period into several shorter time windows. So you've got the first 14 days, 15 to 43 days, the rest of the treatment period while they were receiving prescriptions, and then a short washout period after we think that the patient had stopped receiving treatment, just to separate that time out from the baseline. So remember that the hip fracture could happen at this point, any time during the high risk period, or could happen later on during more baseline time. What's really important to know about this design is that once you've had the outcome, we don't censor you. So the patients who've had the outcome here still contribute the rest of their observation time to the study design. So it's unusual compared to, say, a cohort design where we stop following as soon as people have the outcome. In this design, they remain under observation for the whole period. Okay. So these were the results for the self-controlled case series. So first of all, you've got the tricyclics. And here you've got, in the first 14 days, the rate ratio was 2.3. For the SSRIs during the same period, it's 1.96. And you might notice that the confidence intervals for this analysis are actually narrower than they were for the case control study. This is often a feature of the self-controlled case series, that statistically it can be more efficient. So we can often find that we get narrower confidence intervals in this design. But the other thing to notice is that the effect estimates are lower than they were for the case control design, which was comparing against no treatment. Okay, so I think interestingly here we've got both the fact that the association is more similar for the two types of drugs and that the effect estimate is lower. Okay. So the conclusions that the investigators came to were that, first of all, antidepressants seem to be associated with an increased risk of hip fractures, and this seemed to be true for both tricyclics and SSRIs. They concluded that the increased risk was higher during the first 6 weeks of treatment than later on. They thought that, in fact, the risk seemed to be similar for both SSRIs and tricyclics, contrary to the results of the study that was in the Lancet. They think that the case control approach may have overestimated the association between antidepressants and risk fracture, and that this was due to indication bias or confounding. And that the difference between the two, between the SSRIs and the tricyclics in the Lancet study, was probably due to confounding that couldn't be handled in that case control design. Okay, so any questions about that study before we move on to the next one? Does it, yeah?
I have a question about that, the hip fracture. For example, if from the second time at the hip fracture, is it correlated with the first one? I mean, the before period and during the two kinds of drugs, I mean, before period, do they have some history of hip fracture?
That's a really good question. So this study design can deal with recurrent outcomes if they're independent of each other, and you're absolutely right. So if you've had one hip fracture, your risk of another one becomes greater. So in fact, hip fractures would not be independent. The way that that's handled in this study design is that we only consider the first occurrence. So the condition of being in the study is that you've had at least one hip fracture, and it's the only one that we're interested in. So the fact that you may have a subsequent one is fine. It's not, we're not interested in this. We just want to know the one event which you're conditional on being in the study, when did that one happen in relation to your exposures? Does that answer your question? Yeah, okay. Easy.
So it's not necessarily a question, it's just a random thought. Maybe depression is, in a way, is a protective factor against hip fracture, because people who are depressed, they're less likely to be active. So yeah, that's a random thought.
No, but this is a really good point. So maybe at the point in time when somebody's depressed, their levels of activity also change, and maybe their chance of a hip fracture changes for that reason. In fact, if following the logic of that, we would then maybe expect that their risk of a hip fracture should be lower while they're taking an antidepressant. Or do you think it was during their untreated depression?
Like when they're not treated for depression,
Ah.
they are less likely to have hip fracture because they're not as active, but especially initially when they were treated for depression. When they were treated for depression, that's why the risk of hip fracture is higher, because suddenly they feel like they need to be active, and then as they were going into more treatment, maybe they're like
Yeah.
used to the treatment.
I like this is a really good way of thinking. So we need to think about what else can change over time, and you're absolutely right. So things like activity levels may also have changed over time. I think for I'm not a medical doctor, but I think for antidepressants, it can take quite some time for them to have a beneficial effect, and so I wouldn't expect it to lead to an activity change so quickly. But that's exactly the kind of thinking you'd need to do for this study design, to think what else could change over time, because that's really important. Yeah. Yeah. No, it's a really good point. Yeah. Yeah. Okay. So the thing that really matters with this study design is that, unlike in the case control study where we're comparing against very different people, here we're comparing a person against themselves. And so we are making an assumption that important risk factors are fairly static over the observation period. Yeah? And we'll come back to this later, but keep this in mind. The reason that this is a strong design is because lots of things that differ between people will not differ within a person over the observation period. Some things will, and it's really important that we think about those. Okay. Right, moving on to the next example, which I was just given a paper about literally 2 minutes before we started this session. And it's about rotavirus and intussusception. So rotavirus is an infection that causes severe gastroenteritis, and in the United States about 3.5 million cases a year happen in children under 5, so it's very common. It leads to lots of hospitalizations, about 50,000, and in a given year in the States it could lead to around 20 deaths. So very common infection, very rare but serious potential outcome. So in the late 1990s there was a new vaccine against rotavirus that was introduced and to be given in 3 doses. So the pre-licensing trials suggested that intussusception may be a possible safety issue. This is a problem where the intestine can fold in on itself, and this can be very painful and in some instances can be very dangerous. In the trials, the incidence of intussusception was 0.05% in the exposed and 0.02% in the unexposed. But because these are trials, and even though they'd got 15,000 people in the trials, this wasn't statistically significant. So it's the kind of thing that we would see as a signal of a potential problem, but unconfirmed. So it remained a safety issue, and not long after the vaccine was licensed, there were spontaneous reports of intussusception. So this became a big problem, and the vaccine was initially suspended pending further investigation. So there was a study done using data from the US, and it involved the discharge diagnoses from 19 different states in the US, and involved hospitals with about 75% of the intussusception cases in those states. And the investigators did both a case control and a self-control case series analysis again. So the controls were children without intussusception who were matched on age and who were born in the same hospital as the cases. So the medical providers interviewed the parents of the cases and the controls to determine both their vaccine history and other covariates that they would want to adjust for. And this is a paper that was published in the New England Journal of Medicine in 2001. So here was the study design. So they had the date of the rotavirus vaccine as the start of the exposure, or the start of the hypothesized increased risk period. The first 2 days following vaccination, days 3 to 14 and days 15 to 21. And so this was the period of time that was separated out from the rest of the baseline time. And so remember that all of these kids are going to have intussusception, and the intussusception could happen at any point during the observation. And we're just trying to see, is it more likely to happen during this period? Yeah. They also allowed for the children to have a second dose of the vaccine, or a third dose, and then use the same principle of separating that time out from the baseline time. Okay? So these are the results they found in their analysis. And so interestingly, they did both the case control and the self-control case series. So in the case control study, with their 429 cases and 1,700 controls, they found an odds ratio after the first dose of 22. Now, if you work in pharmacoepidemiology, you never come across these kinds of odds ratios. This is enormous. So clearly a massive association with the vaccine. The subsequent days 3 to 14 after the second dose, the odds ratio was much lower, but still increased. The self-controlled case series, which involved just 432 cases, was pretty similar. So the rate ratio here was 29.4 during the 3 to 14 days after the first dose, whereas it was 6.8 after the second dose. Okay, so both study designs pointing in the same direction, quantitatively slightly different, but both leading to the same conclusion that there was likely to be a major problem with the rotavirus vaccine and intussusception. Now, the study investigators, I think, were right in doing potentially both study designs, because the two designs would have different strengths and weaknesses, and so it's useful to see that whichever approach they took, the conclusion and the answer was pretty much the same. Okay, so I think that increased confidence that their findings were probably correct. Okay, so it was strong evidence of a causal association. They estimated the public health impact of both rotavirus and also potentially the problem of intussusception. So they figured out that between 5,000 and 10,000 infants would have to be vaccinated to generate one additional case of intussusception, and that this could lead to 350 to 700 extra cases of intussusception a year in the US. They decided that because of this, they would withdraw the vaccine altogether. And their reasoning was that although 50,000 children a year were hospitalised due to rotavirus, that this was actually generally relatively simple to manage through rehydration in the hospital. And this is how they weighed up the risks and the benefits of the vaccine and decided what was the best thing to do. Now, interestingly, you could have come to a different conclusion if you were working in a setting where the treatment of rotavirus may be very different and may be very difficult. So if you didn't have the same kind of healthcare and hospitalisation was relatively simple and available, you may have decided that the risk associated with rotavirus was worth it, and so you would actually continue to vaccinate. Here, like I said, the agreement between the two methods was very useful because it increased confidence that the estimates of the effect were correct. Okay, any questions about that one before we move on?
So what if the result from case control and the self-control didn't agree? What would be your conclusion?
That's a really good question. So every time we decide to look at things in more than one way, we need to be careful and think in advance, how might I interpret differences? And often, if you're comparing between a self-controlled study and a conventional design, I think the two things that you would think about carefully are, in the conventional design, I may worry more about between-person confounding, and what do I believe a priori that confounding would do to a result, and that then may help me to explain differences. But at the same time, there are some major assumptions that we must make in order to use a self-controlled design, which I'm going to come on to in a minute. And I would need to again think in advance, if I believe I could break those assumptions, how might it affect my result? I'm not saying that this is easy to do, but this is the kind of thinking I would want to do in advance, just to try to preempt any problems with understanding differences. I think often people will say you should only do one design to avoid this problem. And I'm not sure that I believe that, because the problem is still there. It's just that we don't know about it. And I think that can lead us to have a false sense of confidence in our findings. But yeah, you definitely would need to think carefully about how to interpret that. Yeah. Okay. So for the self-controlled case series, there are some requirements that we have to meet in order to be able to use the design. So first of all, we need to have a well-defined observation period. So we need to know when do we start observing patients and when do we finish observing them, because I need to be sure that during that period I would be able to see if they had both the exposure and the outcome and when they had it. The exposure time needs to be well defined, because if I'm going to split their observation period up into exposed and unexposed, I need to know when to do that. The period of high risk needs to be known to some extent. So for the vaccine study, they knew in advance to break down the period into the first 2 days, 3 to 14 days, and then later periods. So we need to think in advance, what should those periods be? We would need to do that in any other kind of design as well. And the outcome itself also has to be easily dated, so we know exactly when it happened, because we're going to put it precisely on this observation period timeline. Yeah. There's no need for everybody's risk period to be the same length. So if we're looking at a drug treatment that could go on, like an antidepressant that could go on for some long period, it's fine for people to have different length exposure periods. Okay? So why don't we always use this method? Because if it means that we can forget about between-person differences, then surely we should be using it more. Well, the trouble is, we'll come on to in a minute, there are some definite advantages. So because we're making these comparisons within patients, the between-patient differences become irrelevant. And that includes the things that we can measure, like gender, gender, smoking status, that kind of thing. But it also includes things that we can't measure, like genetics, or diet, or exercise, which will often not change that much over an observation period. So it can remove a lot of confounding by indication. Things that do change over time, and typically that's things like age, or anything else that we can measure and that we thought about in advance, like your point, we can then adjust for those separately within our model. So we can adjust for other confounders that change over time, as long as they're measurable. But the limitations can be quite major. So I already mentioned that we have to be able to define our exposure period well, and our outcome has to be well dated. So this method won't work for treatments that people take as needed. So if somebody has migraines and they get a prescription for an anti-migraine pill, they're only going to take it when they think they're going to have a migraine. So on my observation period, I don't know when to put the high risk period. So I can't use it for those kinds of treatments. Similarly, an outcome where the exact start date is difficult to measure will also not be appropriate for the design, because again, I won't know where to put it on the timeline. So things like cancer, which we typically don't know when that starts, we won't use these designs for that. There are also some major assumptions which we started to talk about in Massao's session earlier today, which we have to make these assumptions to do the study, but we need to think about whether they're reasonable. So two which might not be valid are, first of all, that having the outcome of interest doesn't influence the chance of being exposed to the drug again in the future. And I'm going to illustrate that in a second with a diagram. But the problem is, if I have the outcome, so let's say I wanted to investigate whether or not statins are preventing heart attacks. If I have a heart attack today, hopefully you'll take me to the hospital, which is not very far away, which would be good. But then afterwards, my doctor might put me on a statin. Yeah? I think that would be sensible. So me having a heart attack would definitely change my likelihood of receiving the treatment in the future. Yeah? That means that the observation time after the event is going to be biased in favour of being treated. Yeah? It means that the baseline time beforehand will have an artificially high rate of the outcome. So I'm not going to be able to make a good comparison between my high risk and low risk period, because there's something very unfair about the post-outcome observation time. Does that make sense? The second major assumption is that having the outcome of interest doesn't affect the end of the observation period. Okay. So here's how this looks on a timeline. So the first is, if the event increases the risk of mortality, so death itself would be a good example, or something like a stroke, where the risk of dying shortly after a stroke is quite high. It means that we then can't observe what would have happened if the patient hadn't died. And sometimes, not always, this can then lead to a biased result. And it can be very difficult, if not impossible, to predict whether the result is biased. So we ought to avoid the design if we think there's a high chance that it increases mortality. In the second one, here I've got an example where it's the other way around. Maybe having the outcome means that you're then not likely to receive the exposure in the future. So this could be something like, well, the GI bleed that Masao was talking about this morning with antidepressants. Once doctors knew that this was a problem, if somebody had already had a GI bleed, they then might avoid antidepressants in the future. It would mean we then had a long period of observation with no exposure and no outcome, because they already had the outcome earlier on. So we would have an artificially low rate of the outcome during baseline time, and this would be a problem for the design. So how do these assumptions and limitations apply in reality? So events that will influence subsequent exposure, this could include things like, if we wanted to look at suicide attempt and whether it's associated with antidepressants, and this has been a live research question for many years. This design wouldn't be very appropriate, because if I had a suicide attempt, then again my doctor might then put me on an antidepressant, so the outcome would lead to the exposure, and this would be a problem. A more subtle variation of this could be that an illness or an event may prevent somebody from receiving a vaccination in a short period of time. So it might be that if I've got some problem today, it may mean that for the next week or 2 weeks, I'm unlikely to receive a vaccination. We can handle short delays, but if it meant that I would then never receive the vaccination, this would be something that we couldn't handle in the design, so we would have to use another method. And we talked about some outcomes that will often lead to a short-term risk of death, like stroke. And again, if we think that this is likely to be a problem, we should just not use this method. There are some quite sophisticated statistical techniques that people are developing to try to circumvent or get around these problems. And there's a good reference here that talks about the method in general, if you're interested in finding out more. There's also there's a university in the UK called the Open University, and this is where both Paddy Farrington and Heather Whitaker did most of the development work for this method, and they have a lot of open source code lists and programs that you can use with statistical software to use this method to apply to your own data, and they're all downloadable from this website. Okay, so I'm going to move on to the case crossover design in a second. So are there any more questions about the self-controlled case series before we do?
Regarding to the second assumption, the observation period after the outcome. So, such a air pollution, some environmental exposure, some research use the pre and post bidirectional sampling. If the outcome is fatal, for example, myocardial infarction was yes. So in this case, they mentioned the bias about the time tendency is smaller in bidirectional sampling rather than unidirectional sampling. So usually, is it necessary to fulfill the second assumption about observation period in self-control study?
In fact, we've in work that we've been doing along with Heather Whitaker, we've tended to find that outcomes that can increase the risk of death, but only in a small proportion. So I don't know what it's like in Japan, but in the UK, the short-term death rate from MI is less than 10%. So what we've tended to find is that that doesn't lead to a biased result. So although it partially breaks that assumption, it doesn't seem to lead to a major bias, and maybe it's the same with the air pollution. Yeah. Okay, so the next major self-controlled design that I want to talk about is the case crossover. Now, this is similar to the self-controlled case series in as much as everybody that's included in the study has had the outcome of interest. They haven't all had the exposure, but they have all had the outcome. And again, each case of the outcome acts as their own control, and we define several periods before the outcome as either a case or a crossover period, and we compare the risk of exposure during the case and the crossover periods to see whether people were more likely to be exposed during the case period than some other previous crossover period. And I'll show this on a cartoon. So again, we've got somebody's observation time here. They have the outcome at this point here. We can then ignore everything that happens in the future. So this is quite different to the self-controlled case series, where we were allowing people to remain under observation. So we stop observing people at the outcome, and we will look at this case period and see whether they had the exposure we were interested in, but we will then also look at potentially one or more control periods earlier on to see whether they had the exposure then. Yeah. So relatively straightforward, a bit like a case control study, but where everybody is their own control. Yeah. So in its simplest form, we just have one crossover or control period, and we contrast that with the case period. So you could, in theory, do a case crossover study just with a calculator. You don't need any fancy statistical software at all. That's all you need. The example I'm going to tell you about is one about benzodiazepines. So these are drugs like Valium, which they can cause drowsiness, and this is well known. The research question was, does being prescribed a benzodiazepine increase your risk of having a road traffic accident? Okay. So confounding is likely to be a problem in this study question. If we wanted to use a conventional design like a cohort or a case control, the worry would be that people who are prescribed benzodiazepines are very different to people who are not prescribed them, and that maybe the indication for a benzodiazepine, such as anxiety, may also be associated with road traffic accidents. So finding a good comparator group for this question, I think, would be very difficult. So the study that was done was in a small region of Scotland which is in the north of the UK. And this was over a 3-year period where they were able to get full prescription data for everybody who lived in that area. And they found that 20,000 people, or drivers, were involved in a road traffic accident during that period. Now, this region of Scotland is quite small, so I would say if you ever visit the Tayside region, just be careful if you're crossing the road, because if they have 20,000 car accidents in 3 years, I think that's not great. Anyway, the day of the road traffic accident was the case period. So we were interested in whether or not they were receiving a benzodiazepine on that day. The investigators compared that with the risk of receiving a benzodiazepine on the same day of the week during the 18 weeks before the road traffic accident. Why do you think they chose the same day of the week?
If it's a work day, they go to work, and or in the weekend we go to supermarket, like those
Yeah.
the similar situation.
Yeah. So that we're comparing similar behaviour patterns on similar times of the week. Yeah, exactly.
Would the weather be a confounding factor?
Weather could be a confounding factor, yeah, that's a really good one. I think that would be more of a problem if everybody was having their RTA on the same day. But there could be some problems with, they may have been more common on some days of the week. Yeah, that's actually a really good point. No one has ever asked me that before, and I don't know that the investigators took that into account, but actually it's a really good point. It would have affected the road traffic accident. Whether it would have affected whether somebody took a benzo that day, maybe less certain, but it's a really good point. With all of these self-controlled methods, the really key thing is to think what else could change over time and that I might need to account for in the analysis. Yeah. Okay, so in a cartoon style, this is the design. That's the day of the accident. And we see, did they take a benzo on this day? And then see for all of these previous 18 weeks, did they take a benzo on any of those days? So they found that 235 of the drivers were taking a benzo on the day of the accident, and that on average, only 147 were prescribed a benzo on one of the other non-road traffic accident days. And so the within-person odds ratio was 1.62. So in other words, yes, there did seem to be an increased risk of having an accident if you were taking a benzodiazepine that day. Okay, so in lots of ways, this is a more simple design than the self-controlled case series. It makes fewer assumptions. It also, I haven't got time to go into it particularly today, but it does assume that the risk within the whole population of receiving a treatment is static over time. So if we go back to this example here, let us imagine that rather than weeks, this was years. So if this is 18 years before the road traffic accident, let's imagine that the rate of prescribing of benzodiazepines has changed drastically over 18 years, and that everybody in the population is more likely to be prescribed a benzo here than they were there. It would mean that I would find an artificially increased risk associated with having the outcome. So there is an assumption that the rate of prescribing in the population is the same over the time period. This isn't the case for the self-controlled case series. It doesn't matter for that design. Okay. So to summarise, for case-only designs, they make comparisons within individuals. The key strength is that this means that they can overcome between person confounding. Anything that can vary over time within an individual and be a confounder can remain a problem, and we need to account for them if possible. They can be very statistically efficient, and within a given population we may have narrower confidence intervals if we use a self-controlled method. And they can be good for investigating the temporal association between an exposure and an outcome, as you saw with both the antidepressant and the rotavirus examples. Both of them work best for acute exposures, or at least a well-defined risk period. So we need to be able to define when somebody's exposed to a treatment. And they both work better for outcomes that we can date well, and we know when the onset occurred. The risk periods, so the 0 to 2 days, 2 to 14 days, whatever we think it is, those periods are chosen by us as researchers. Sometimes, if there's a very broad signal of a safety issue, we may not know what those periods should be. But this would be similar for any study design. They do make important assumptions, particularly about the relationship between exposures and outcomes and how that changes over time. We need to be very careful about those before we do the study. Okay, and that's all I'm going to say for now. So any questions before we move on to, I've got a workshop for you to have a look through, but do ask questions.
So how to design the period of the case and control? So the period, the duration.
Is this for the case crossover?
Yeah, case crossover method.
Yeah, so this is going to have to be driven by hypotheses about the exposure and the outcome and how the drug is taken. So for that example, with the benzos, they would have thought, if somebody took a benzodiazepine 3 days before the accident, I'm not interested, but I really want to know were they taking it that day. If you were looking at something like, let's say you were interested in liver injury and an antibiotic, I think I would want to know that somebody had taken the drug maybe up to 2 weeks before having the liver injury, but maybe if it was earlier than that, I would be less bothered. It would depend on what I thought the mechanism was. So you'd need to think biologically about what the mechanism is between the exposure and the outcome, and then define what you think should be a reasonable risk window. Yeah?
So I'm a little confused the difference between the case series and case crossover design. That is a difference of control sampling. So in the case control design, we choose the narrow field sampling. And when we use the case series, we use all other fields as a control.
Yeah.
That is
So yeah, they're kind of analogous to, so the self-controlled K-series is similar to a cohort design in that we are first of all defining exposed and unexposed periods of time, and then comparing what's the risk of the outcome during those periods. Okay, so that's the self-controlled K-series. The case crossover, it's more similar to a case control design because we're starting at the outcome and we're saying what was the risk of being exposed compared with some control periods where we know you didn't have the outcome.
That is the reason why the second assumption, the observation period after the outcome
Yeah.
is necessary.
Yeah, that's right. Yeah.
I understand.
I'm wondering how you can handle possible confounders. You know, for example, second example, anxiety. How can you handle this?
If it's something that you can measure and it's in your data, you just put it in the statistical model in the same way that you would if it was a cohort study or whatever it is. If it's something that you think changes over time and which we can't measure, like anxiety level day to day, we just have to claim this is something that a problem that we couldn't do anything about. There is definitely some issues that we can't handle.
You can mention the limitation.
Yeah.
I see.
Yeah.
But I think that method about to give the more weight for the control period that is close to the case period, and give a less weight to the further period. I'm not sure whether it is also such kind of case that.
Yeah, there's a slight variation of the case crossover that's called the case time control. And I can find you the reference for this as well, but where you can take into account the fact that the population level trend can change. But that would be another way, is by giving more weight to the period that's closer to the case period. Yeah. Okay, right, so we've got half an hour, which you may get partway through. What I'd like you to do is to work in small groups, so maybe up to 4 people. And I'm going to give you some examples here of study questions that I'd like you to just think through. How might you go about designing a case-only study? And I suggest that you work on either number 1 or number 2. Decide for yourselves. But there are published papers on all of these questions. There's not necessarily one correct way of doing anything, but there are different ways that you might approach them. Okay? But do please work in small groups, because I think you'll benefit from talking to each other. Okay. Now I suspect you didn't finish, am I right? But you got some way through, maybe? So which research questions did you look at? So this group here.
We chose flu infection, myocardial infarction.
Okay, flu and MI. And this group?
The same one.
Same one? And this group?
HPV and GBS.
You did HPV and GBS. Okay, so obviously we don't have very much time, and I'm going to say, so because 2 of you chose the same question, we'll talk about this one. But what I will do, there are published papers using a self-controlled method on each of these questions, and I've sent the papers to Jar, so she'll email you the papers so that you can read what people did. So as I say, there isn't necessarily a right, there'll be lots of wrong ways of doing something, but there isn't necessarily just one right way. So it's just interesting to find out what you did. So amongst your groups then, so which of the 2 controlled or self-controlled methods did you decide to use? Which one did you use?
We chose crossover.
So you chose the case crossover,
Yeah.
and
We too.
you also did case crossover. Okay, so that's good. Why did you choose case crossover and not the self-controlled case series?
It's kind of because the case of myocardial infarction is kind of like outcome based, so people only case who have experienced the outcome will be considered.
Yeah.
And also each case have 1 or more risk period.
Yeah.
And
But why? So why that method and not the self-controlled case series?
I guess compared to the other one, we don't have a well-defined observation period. Like we don't have a well-defined period of high risk. Think I guess flu season would be high risk.
The flu season's high risk, yeah. How about this group? Why did you choose?
Our reason is because the period of exposure is usually limited with flu infection within 1 or 2 weeks. For acute exposure, maybe case crossover is more suitable than case series.
Okay, I think that either would work, but I was curious about why you may have chosen one over the other. I don't, like I say, there isn't a right answer, and I think either method would potentially work. Okay, so how did you define the exposure period?
Flu season.
The flu season, but you want to know on an individual level whether somebody's been exposed to flu. So it could be flu, let's say flu season right now, but I don't have flu. So how are you defining exposure?
We define 2 weeks after flu infection. In Japan, most patients visit to clinical hospital if they are affected to the influenza.
Aha.
They can freely prescribe anti-flu drugs in Japan.
Ah, okay. So this is a really useful feature of your healthcare system, that you could define who's got flu. So this is going to be really important when you're approaching this kind of a question, is to make sure that you'd be able to ascertain or find whether people have got the exposure. So you've got a great example there, the flu you can identify. Okay, so that's a good way of defining it. And then your risk period. So I think did you say 2 weeks, was it?
Yeah, or 1 week. 1 week, yeah, 1 or 2 weeks.
So 1 week, and so why did you choose 1 week? So basically you're going to say a week before the MI, did somebody have flu? Is that right?
Yeah.
Okay, so why 1 week?
It's very based on our assumption, like 1 week, that's how long the flu will take.
Okay, so that's,
Those are assumptions.
yeah, that's a good thing. So you've thought about it should be a fairly short period, and we're going to go for a week. What did this group pick?
Depending on my clinical expertise.
Depending on what, sorry?
Clinical experience. 2 weeks seems reasonable.
Okay, so we may vary slightly, week, 2 weeks. What you might want to do is have potentially a sensitivity analysis. So whatever period you choose, we often don't know for sure what that period should be, and so what you might often do is say, my primary would be 1 week or 2 weeks, but I may look at a shorter or longer period as a sensitivity analysis. So that would be a useful design feature as well. Okay. What did you think about people who have more than one episode of flu? Could you have more than one episode of flu? How would that work?
It's unusual. Usually, so during one season, one patient suffer. Most patients suffer only once.
Yeah, I think so too. What you may find when you do record using or research using electronic health records, you will find impossible people. So you may find people who've got more than one episode of flu in their record. Now, I'm not asking you to find a solution right now, but I'm just telling you this will definitely be a feature of the data, that you will find something that should not be possible. So you would then have to decide, if somebody has more than one episode of flu, how do I treat them? Do I throw that person out altogether? Do I treat the first one as flu, the second one as flu, both of them as flu, knowing that they both can't be? So you'd have to have some way, a bit like this morning Masao talked about, the kind of questions that he had to face when he was looking through the data to then progress with the study, and you would need to think what to do about each of those situations. Okay, how did you define the outcome? How would you know whether somebody had the outcome?
Myocardial infarction.
And how would you know that somebody had an MI? Official diagnosis, yeah. So if we were working in electronic health records, then we would potentially have a code list, which hopefully somebody has already validated. Because to do a validation could be a year's work for somebody. It could be a very long process. Okay, so you got your MI, and did you have a different way of defining, or?
Similar way. In Japan, foreign countries, myocardial infarction is already validated with administrative data risk, and the PV is usually high. Yeah.
Okay, so I think it is an outcome that we would think we're going to know if somebody's had an MI, so that's a good thing. Were there any assumptions about your method that you chose? And one thing that you mentioned to me was something about the flu season. So how did you take that into account in your design?
kind of compare.
So you'd go back over previous flu
Yeah.
seasons?
Yes.
Ah, okay, that's one thing that you could do, yeah? You would then need to account for age?
Yeah, age.
Yeah.
Kind of like, I don't know how, I would assume traveling would be a confounding factor, but I don't know how to
Could be.
like do with that.
Yeah, you maybe couldn't. So I think you would have to assume that travelling was not introducing a big bias, because I don't think you could easily get information on whether or not your cases had been travelling to a different flu season during the periods you're interested in. Yeah. How about you? Any other?
So we also use the only winter season in study field, and one assumption is the temperature is not so severely changed.
Uh-huh.
And,
I don't know if, because obviously there might be different types of virus. I don't know if there can be like official record to show the trends of different viruses across different seasons, different months.
Yeah.
And I don't know if flu shots is a thing here.
If what, sorry?
Flu shots, flu vaccination.
Ah, flu vaccine's a really good point. Yeah. Yeah.
Yeah, I don't know if that's a.
So I think there are some quite big issues with it. So if you're going to compare across different flu seasons, then the previous season, the flu would have been a different strain, maybe less people got flu, there would have been differences. If you're looking within a season, then of course the spread of flu is not going to be static throughout. So I think whichever way you choose, there are things that you would then need to think about to then get what you think is the best design. And then I know that we're out of time. And you've talked about some time varying confounders, you've talked about travel. Were there any others, and also the flu season itself, was there anything else that you thought may change with time?
Temperature, global warming.
Ah, temperature's a good one, yeah. So we know that temperature, in fact, particularly in the cold season, or actually depends what country you're in, maybe less so in Japan, but in the UK, we find that in the summertime, the risk of myocardial infarction doesn't really change. In the wintertime, when it can be very cold, then the risk of MI goes up. In countries that are hotter, it's the other way around, where if you're going down to maybe 0, -1, that doesn't matter. But if you're going up to 40, then sure, that really matters. So the temperature can matter depending on where you are. Okay, I'm going to stop us there because we're going to have a break. But thank you very much for that. Even though you didn't have long, you came up with some really interesting thoughts. I'm sorry we didn't get to your question, but we will send you the papers for both examples. Okay, thanks very much.